I'm excited to speak to you today because you are the next generation of change makers, and I hope to inspire you to come join me in my work. So I am an international and domestic public health specialist, and I link individuals who are vulnerable and stigmatized to healthcare services. And I try to create access in a sustainable fashion. And so my journey actually started in Bangladesh, where I started to get into healthcare development. And I volunteered with a local organization in rural Bangladesh that is affected by floods. And I would wake up every morning and I would see a line of women standing before 7 a.m. waiting to see me. The female doctor that was in the region and the only one in the region, and they're waiting to see me to talk to me about their gynecological problems. And I saw this line for the first time when I was in Bangladesh, and I decided that I was going to devote my career to making sure these women would always get sustainable access to care and other people around the world. And so throughout my decades of work, here and abroad, I learned three crucial aspects of healthcare sustainability and access development. One is that when individuals want or need care, it's not always available. Don't assume this. And very importantly, if one person needs care, many others will need that too. Second, very importantly, people's lives are dynamic. People's lives change over time in terms of how much money they have in their pocket, and also how they can take off work and how they will get to the clinic. One day you can have insurance and one day you won't. And you have to take this into account very early when you make healthcare programs. And very importantly, one organization actually won't be able to accommodate that person's needs. You actually need a network of organizations that can speak to each other to accommodate the dynamic changes of someone's lives. And three, access should always be made long-term and sustainable. The women standing before you would walk 4 hours in the morning to come see me in the scorching sun, leaving a day's worth of work on the farm because they had to go back. And they would bring their grandmother, their mother, their sister, and their daughter. And they had hoped to see a female doctor and talk about cultural sensitive issues. And they needed those services today, tomorrow, and for decades to come. And creating long-term access for decades is very hard. Organizations have to integrate services into their routine practice. And very importantly, when an organization has to think about this within time and space and budget constraints, they wrestle with three competing factors. If I provide access and I expand access, how can I make these services affordable? And how can I maintain that quality? So, how does one approach the complex task of building healthcare access, a problem that spans the globe? I'm going to describe this in a three-pronged approach, and I'm going to do this by bringing you into my clinic in St. Louis, Missouri, where I'm an HIV prevention doctor. And I first want you to meet Michael. And Michael's in the audience today. Michael, where's your hand? Raise your hand. And so Michael came to my clinic 5 years ago because he had heard about the HIV prevention pill from a friend of his. And so Michael was so devoted to figuring out this HIV prevention pill and what it was, he actually took a sick day of work because his work wouldn't let him leave to go to the office. And in fact, Michael, this was his second stop in his healthcare journey. He had gone to a location closer to his home, and the doctor said that they did not know about the HIV prevention pill, and they did not want to be a part of that kind of HIV-related care. Because Michael is a 30-year-old gay man, and Michael is part of a stigmatized population. And very importantly, the services he was seeking is also stigmatized equally. So Michael and I discussed PrEP, and he was right. There is a pill. There's a pill, one pill once a day, 90% effective if you actually take it every day. It's called PrEP, pre-exposure prophylaxis, or PrEP. And Michael was very, very keen on one other thing. He knew he was at risk for HIV. Michael falls into the statistic of 1 out of 2 African American gay and bisexual men have a lifetime risk of HIV. That's ridiculous. So we're not getting this pill out and meeting its potential to curb the epidemic. So Michael and I discussed the pill and PrEP. I prescribed it, and I scheduled a follow-up appointment, only to find a few months later that Michael called the clinic and said he didn't have insurance. And he explained to me, I don't know what to do next, and that his employer had reduced his work week hours from 40 hours a week to 39.5 hours a week. What does 30 minutes matter in Michael's life? He lost his insurance eligibility, and large retail companies are doing that to young adults like Michael. And so when he lost his insurance eligibility, Michael used to pay $30 to see me, the office visit for a private sector clinic, and he got his labs and his medications covered by the insurance company. This total cost about 3% of Michael's monthly income. But now uninsured to come to the same clinic, Michael would pay over $700 at least to come to the clinic, get labs, meds, an office visit. But that would be over 75% of Michael's income. So the next step is I tried to get Michael insurance. But based on Michael's insurance eligibility and his income, in the state of Missouri, the only thing Michael could get was the Affordable Care Act. And so Michael would have to pay $5,000 as a deductible out of pocket first before his insurance kicked in, and he would actually have other things covered. And what's really important here is Michael would have been part of the underinsured. And when you look at healthcare access, there's the underinsured, the uninsured, and the fully insured. And when we develop healthcare access, we often overlook the underinsured, the people that have to pay thousands of dollars out of their pocket before their insurance actually covers them. And it's usually in fine print, and people don't know about it, especially young adults who are not knowledgeable about this system. So I tried to get Michael very quickly transitioned into another clinic that serves the uninsured. However, the doctors there did not know about PrEP and could not prescribe it. So not having a doctor for Michael kept me up at night. Why did it keep me up at night? Because Michael might have to stop his pill, the PrEP pill, and if he stopped the HIV prevention pill, he's at risk for HIV. And I, as a doctor, I signed the Hippocratic Oath of do no harm, which I'm bound to, and it is my job to help Michael help prevent HIV for him. And so I gathered a team of activists, providers, and stakeholders in the region and created a community advisory board to address this problem in 3 broad steps. 1, know your community. 2, know the organizations that can serve them. And 3, link the community and the organizations together. First, knowing your community entails understanding that Michael as an individual exists. He's got peers and friends, and they make up a community, and you need to know what they want and need. So we went door to door. We visited bars, clubs, bathhouses, coffee shops, other places where we could talk to people at risk for HIV and ask them, do you know about PrEP? Where would you feel comfortable going to get PrEP? Where would you feel comfortable having a conversation about your sexual health where you won't be stigmatized? How much can you afford? And actually, how will you get there? Do you have a car? Are you going to use public transport? Number two, knowing the organizations that could potentially serve the uninsured means mapping out the organizations, which we did, that were in the entire region and were known to serve the uninsured. And we also mapped out if they were on public transport lines. And we also saw their potential to be safe spaces in St. Louis and Missouri, where people would want to have a trusted conversation and not feel stigmatized. We identified federally qualified health centers, a pharmacy, other locations, an immigrant refugee clinic. And then I went door to door and spoke to CEOs and medical directors. And what I did is I discussed how do we seamlessly integrate PrEP services into routine care? Is this feasible? What are the tools you need? What would your budget be like? Would we break your bank and budget? Would you not meet overhead costs? In essence, I was trying to advocate for HIV prevention within the organization's mission, priority, and organizational routine practice. And so we did that because we wanted to ensure that these services would be delivered long-term and sustainably. And this is important because Michael and his community, like the women in Bangladesh, need services today, they need services tomorrow, and they need services for over a decade. And so then the team went ahead and conducted provider education sessions. We made an online PrEP Missouri implementation toolkit, which aids implementation among multiple organizations and helps to implement along three very important layers: the organizational and the admin layer, the provider layer, and among patients. And then we hosted medical directors to come to our model clinic and observe PrEP care. And then the final touch was supporting providers throughout this region and hand-holding them through patient cases, through phone calls and texts and emails, and making sure that they had their support and that everybody was having a positive experience in this system, both the patient and the provider and the medical director and the CEO. So when we generated new access points for PrEP care in St. Louis, then we put it all together, and that's the third step. We went ahead and created a network of organizations that can speak to each other and are of different types and are at different locations, are on all of the public health transport systems so you can get there without a car. And most importantly, they're vetted as safe spaces so people can go and talk about their sexual health or anything else they need without having any stigma. And then we advocated the Missouri Health Department to launch a website to centralize this information and put all this on a website with the network. And what that does for us is, in retrospect, that would have made it easier for Michael and I to get Michael care quicker. And so it was very important we made a roadmap of where can you get care based on those three things. How much can you pay? Do you have to leave your job? And very, very importantly, how do you get there? And so when you do this in summary, by going ahead and looking at Michael's lessons learned from his case and sharing it with the region, we wanted to make sure that the challenges were not faced by anyone else. And the summary of these three steps of knowing your community, knowing the organization, training up the organization, and then linking everyone together, that creates access to care. That's really important. But making it sustainable is by integrating PrEP into the organizational structure so that it fosters sustainability and long-term services. And no one gets let down. So Michael never stopped PrEP. He received care when he was uninsured. He even got insurance. And Michael returned to my clinic, and I see him to this day, 5 years later. And in that same light, across 2 oceans in the Bay of Bengal, I trained lay female workers in basic gynecological care, and I integrated them and their services in the existing organization in those flooded regions of Bangladesh. And these women standing in front of you have access to women's health care today, over a decade later. So when you embark on your careers to the next generation of change makers, wherever in the world that you are, please remember these stories, these points, and this approach. And you must advocate and ensure that every individual has access to care that's affordable and is of the quality of what the community wants, needs, and deserves, but most importantly, is sustainable. Thank you for your attention.